Thank you all for joining us. Hopefully will be a good night of informative chat about Achilles tendinopathy. We're lucky enough to have a few experts joining us tonight. Firstly, we have tonight speaking will be Peter Malliaras. So Pete is a world-renowned researcher in tendinopathy. So he's based at Monash University. He works clinically at Complete Sports Care in Melbourne. And he consults in a wide range of tendinopathy cases, both locally in the clinic, but also abroad via telehealth. So thanks for joining us, Pete.
Thanks, Dave.
And our second presenter tonight is Dr. Andrew Aldous. So Andrew is a sports and exercise medicine physician. He's based at in the Geelong and Surf Coast region, and he consults a wide variety of sports down on the Surf Coast area. So thanks for joining us tonight, Andrew.
Thank you.
And last but not least, on the panel, we have Tim. So Tim's not speaking tonight, but Tim Travail. So Tim's a myotherapist. He's the program director of the myotherapy program at Torrens Uni, and also a PhD student of Pete's. So Tim's going to help me out a little bit with the Q&A tonight. So thank you very much for joining us, Tim.
Thanks, Dave.
And very lastly, I didn't introduce myself. I'm David Thwaites, so I'm a physio at Complete Sports Care as well. So before we start tonight, I just wanted to give you guys just a little bit of information about the Q&A function. So this is how we're going to be running our chat at the end. So we do have that dedicated time slot at the end that will pose a few of the questions to the speakers. But we will be using that function. So we want you to really start asking questions as soon as you feel you want to. So start filling that Q&A box, and Tim and I will field some of those questions as we go, but we'll save some of those questions for the two speakers at the end as well, so we can have a good discussion about some various points. So yeah, by all means, we encourage you to use that Q&A function. So let's get started. So we'll start with Pete tonight. So I'll let Pete introduce his talk. So let's get
very much. Thanks, Dave. Thank you, Dave. I'm just going to share my screen here. Can everyone see that? Can you see the screen there? Yeah. So look, thank you very, very much, Dave, for organising this, and thanks to everybody else for people who come. The sort of audience, and thank you to everyone else that's speaking. Thank you for putting it on. It's yeah, it's good to get back into doing some presentations. So basically, I will be talking for a bit, and I thought I would do something a little bit different today. I usually talks like this, we'll do like clinical stuff where I'm talking about say, you know, assessment and management, but I wanted to focus on physical function markers today, and talk about how they're relevant from the perspective of the Achilles function through to assessment and through to management. Okay, so it's not going to be as clinical. I'm not going to talk about pain very much at all. Just going to talk about these physical function markers, okay, and relate it to some of the aspects of Achilles. So just a quick question to get everyone warmed up to start with: did Achilles the warrior actually exist? So if you can use your, I don't know if I can see people, I can't see anybody. Usually what I do with this is get people to put their hand up, their Zoom hand up, but that's okay. Just think about that question. Maybe we can get some responses on email later, on the chat function later.
A few hands raised, Pete. There's a few hands popping up.
Oh, fantastic. Okay, so we'll talk about that later. But obviously, Achilles, the name of the tendon comes from the story by Homer in Greek mythology, where Achilles was a warrior with incredible strength, thanks to being dipped into the river that gave him pretty much immortality aside from his Achilles heel. So there's a lot of parallels, I think, with Achilles tendon. And the story of Achilles the warrior in terms of his strength, in terms of how different the Achilles tendon is to a lot of the other tendons that we see around the body. So I just wanted to relate that a little bit, sort of feed that into some of the aspects of this talk that I'm going to give. But really, it's going to be focused around physical function capacity. So I was very fortunate probably 3 years ago to be one of 28 world experts in tendinopathy looking to develop core outcomes for tendinopathy. And we sort of had a consensus group meeting where we came up with 9 core domains that should be considered in terms of outcomes for tendinopathy. And one of them was physical function capacity. And physical function capacity basically is any sort of physical test. So defined as physical tasks performed in the clinic. So it could be dynamometry, it could be number of hops, could be timed stair walk, etc. And obviously this relates to all tendinopathies, not just the Achilles. But it's probably our sort of Achilles chapter of the consensus group has gone on to look at a review of all the outcome measures that have been used in Achilles tendinopathy literature, and probably one of the most poorly reported is physical function capacity. So people just are not, even in trials, measuring it that much. And that is, if you do an exercise intervention, which is what we mostly do with our patients who have Achilles, do we know if it's having an effect on their physical function capacity, aside from just self-reported measures? And the answer is probably not, because we're not really measuring it, okay? So that's sort of where my interest in this has grown from, and we're doing a number of studies looking at physical function capacity. We've been doing them for a while, but we're sort of starting to move into that area even a bit more. So I just wanted to talk a little bit about the Achilles tendon and how it is potentially different to some of the other tendons that we see. And the key difference is that it's an energy storage tendon. So that word gets sort of used a lot, energy storage tendon, but it only really truly applies to the Achilles and possibly the patella, depending on who you speak to. But a tendon that stretches and absorbs energy and then harnesses and releases that energy, there's no tendon in the body that does that to the level of the Achilles tendon in everyday function. So it is different to other tendons. And we know that these energy storage tendons, like the Achilles, they have a high risk of injury. They're relatively compliant, so they can take more strain and store energy. They have a high glycosaminoglycan content. Now, these are the proteins that bind water, and that's interesting. We'll come back to that later on, why that might be the case. They also strain a lot, and that obviously is related to the increased compliance. But when you put load under them, they strain a lot, and they harness the energy, and they use that energy to make us more efficient. And that's in direct contrast to the positional tendons like tibialis and anterior, which you sort of never hear, about in terms of injury, unless it's sort of a sheath problem. But generally, these tendons are stiff, and they're there to transfer load from the muscle to the bone as quickly as possible without really any storage of energy. Okay, so they're very, very different. And probably the best way to think about stretch, shorten, cycle is to think what the differences are between stretching and between walking. So if you look at the Achilles in mid-stance and the Achilles when someone's doing a stretch of their calf, pretty much the biomechanics or the mechanics of the joints are the same, but what's happening in the muscle and the tendon is inverted. So with walking, the tendon's storing energy. With stretching, the muscle is storing energy and stretching. And it's just about which spring. If you think about the Achilles and the muscle as two springs in series, it's really just about which spring is the most stiff at any one time for any one task. So when you're doing things like stretching, the muscle is relaxed, so it's less stiff. Whereas when you're doing things like walking, the muscle is very stiff, it's contracted. So therefore the tendon stores energy. So the stretch, shorten cycle generally will occur when you're doing tasks like running, jumping, and hopping, and walking. So really, what happens during the stretch, shorten cycle is that as we sort of talked about, the muscle is quite a stiff spring in these functions because you're undergoing high load activities, and because the muscle is such a stiff spring, the tendon starts to become very elastic and it takes up a lot of energy. So in this you know, sort of, I guess you could call it the loading phase of these activities, in that sort of phase where you've got maximal elongation of the muscle tendon unit. You've got a lot of stretch in the tendon, and that happens, you know, for all of these impact load-bearing activities like running, hopping, and walking. We'll talk about some of the benefits of that stretch, shorten, cycle activity in a second, but just moving on to the, I guess, the structure of tendon, because the structure of tendon sort of allows the Achilles to do this stretch, shorten, cycle, and allows it to behave in this way. So pretty much everyone has seen this schematic diagram of a tendon, and the things to remember are the 3 Fs. So fibril, they congregate to make a fiber, they congregate to make a fascicle. So it's the 3 Fs that you want to remember: fibril, fiber, fascicle. And basically what we know now is that there is movement between the fascicle layers. So if you look at these fascicle layers, it's what we call the intrafascicular matrix. So the sort of soft tissues, the connective tissues, you could say, between the fascicles, they undergo sliding during human movement and function, and that is where a lot of the stretch and the energy storage within the tendon occurs. And there are changes in this function as we get older, and also with Achilles tendinopathy and disease. So inter as opposed to intrafascicular, interfascicular, so in between different fascicles, you're going to have this sliding that happens between tendons, and it only happens in energy storage tendons. The fascicles are on an angle, so there's a greater angle of the fascicles, and you also have some, and that facilitates some of this sort of energy storage within these fascicles and between the fascicles, but also you have some rotation between these fascicles that occurs, and that's also harnessed in the Achilles because you've got a twisting of the Achilles as it comes down from the calf to insert into the calcaneum. So all these sort of, you know, I guess, idiosyncrasies of the Achilles contribute to its ability to store energy, and is the reason why it's so good at storing and releasing energy. So this energy storage has real advantages when we look at energy conservation. So if you think about the muscle tendon unit, you've got a tendon component, which is a free part of the tendon, and then you've got the muscle component, and the muscle also has a tendon component. That's an intramuscular tendon, and that's where all of the muscle injuries that we see occur, you know, things like old man calf injuries, which are so common, they probably have something to do with fascia, i.e. the intramuscular tendon, and changes in the ability of that fascia to function as it should. The key point is that you've got decoupling between those tissues. So when you do things like hopping and jumping and walking, you sometimes can have very different things happening in the muscle part versus the tendon part, and that's because of the muscle being such a stiff spring when you're doing these things, and the tendon just becoming so elastic, okay, like we talked about earlier. So that harnesses and that sort of decouples the movement. So you can have fascicle shortening and the tendon lengthening at the same time, okay? So even though the muscle tendon unit is lengthening as you go into mid-stance of running, or as you go into the absorption phase of hopping, you're still going to get potentially shortening of the muscle, or near isometric function of the muscle. This is a PhD student from Melbourne Uni who did this a while ago. He's now, I think, overseas doing a postdoc, but from the group of Marcus Pandy, who's a modeler at Melbourne Uni, and they've done a series of studies looking at muscle tendon unit, MTU, muscle fiber, and then tendon properties during running at different speeds. And what they have found is that if you look at this is just the gastroc and the soleus that they're showing here. If you look at the muscle tendon unit in the mid stance of running, yes, it's lengthening overall, but most of that lengthening is being taken up by the tendon, particularly the soleus tendon, as opposed to the well, the gastroc is lengthening as well, but as opposed to the muscle. So certainly the muscle fibers are not lengthening very much at all. And that, if you think about the metabolic cost of human movement, it really does come down to muscle fiber lengthening. So the more your muscle fiber is lengthening, the more metabolic cost you have when you're doing things. So it is really advantageous to have a tendon that takes the energy and allows the muscle fascicles to work in a more optimal range. It saves a lot of energy. So it really is the reason why we can walk for hours and hours and hours. So if you look at the stretch shorten cycle, there's also obviously not just a tendon component, but also a neuromuscular component. So with the neuromuscular component, pretty much you have a fast stretching of the muscle in the eccentric phase, followed by reflex and active activation of the muscle, and that enhances the power generation within the stretch shorten cycle. So as well as the storing of energy in the tendon, you've also got reflex activities that happen, and you need to do things quickly for that to really be optimized. So I think this is a really good snapshot into rehab, this sort of thinking about the stretch shorten cycle, because what we need to do in rehab is we need to be able to allow the muscle tendon unit to behave like it does in a stretch shorten cycle. So very strong, fast rate of force development, strong muscle contraction, as well as really good tendon elasticity. Okay, so they're the types of things that we need to think about in our rehab. So thinking about stretch shorten cycle, I've sort of talked about this already, but you think about muscle and tendon as two springs, and the muscle is a very stiff spring when you're doing things like hopping and jumping, and the tendon is a much more compliant spring during those activities. The other thing to consider with tendon is that it does take a lot of forces when you're doing things like stretch shorten cycle activities. That's probably why there's that risk of injury that we talked about. So running can be up to, in this image here, 3 times body weight, but it probably could be much higher than that depending on how you're running. And also the technique varies. This is ultrasound, direct measures of ultrasound, looking at muscle tendon elongation and relating that to forces. But the other thing to think about is that all these tendons within the fascicles are shifting at different times and different, so it's really complex, the behavior. And what this does is just take a very gross measure at one single point. So it can't really tell you about how much strain there is in all the different parts of the tendon. So this is work of my PhD student, Igor, and I'll talk about his work quite a bit during this lecture, because there's quite a few studies that he has done and he's doing. Please don't tweet this one, because this isn't published as yet. But basically, it reinforces the point about the forces taken by the Achilles tendon. So he's done some work in a lab where he's looked at different activities that you might do in rehab. So double leg all the way up to double leg calf raises, single leg calf raises, walking, moving into hopping, running, and he's shown the body weight forces so this is normalized to body weight force in the Achilles tendon. And you can see it goes up to about 6 times body weight for hopping. But there's a clear difference between doing things that involve hopping and running and doing things that involve rehab. So again, with our rehab, if you're going to be doing a good job of rehab, you really need to progress beyond just doing calf raises and loading slowly. So we need to think about developing the sort of, the muscle strength, the rate of force development, the power that people need to develop, to do these stretch shorten cycle activities. It's not just the tendon, it's the muscle and the tendon acting together. Mechanotransduction. So we know that as with muscle, you can make a tendon stronger if you load it. So this is really important to consider as well. So we know that there are cells, the tenocytes in the tendon. They're joined by gap junctions there's what we call a cytoskeleton, which is basically how the matrix transfers load to the cells. So whenever you load a tendon, the cells sense that, and there could be all sorts of shear and compressive and tension type loadings that lead to some response. So this is important for us to know, because it will we can make a tendon stronger, just like we can with muscle. This is a systematic review by the German group, Aaron Patzis's group in Berlin, where they basically took all the studies that have looked at stiffness in the patella and Achilles, stiffness changes with rehabilitation, and reviewed that literature. What they found is that studies that do high load interventions, which is generally above 70% MVC or above 1 RM, so you need to work with a rep range of 10 or less, so getting them fatigued at a rep range of 10 or less, they will lead to adaptation in the tendon in terms of stiffness. The tendon becomes stronger, if you like. If you're not doing those intensities, you're probably not going to see adaptation. So that's also really important to consider as we move into how can we set our rehab up. One of the interesting things is that you do have, if you look at something like a maximal isometric plantar flexion that someone can do in, say, as much weight as they can tolerate in a leg press machine, and you compare that to something like a hop, the body weight loading is almost double in the hop, even though this is a maximal isometric contraction. But that's not really the main difference. The main difference that we see going from slow isometric loading to doing loading like hopping is the loading rate. So the Achilles loading rate is pretty much almost 30 times greater in the hopping function, whereas this is only factored up by 2. So we think that the loading rate has something to do with the way the tendon is able to cope with loads and possibly leading to injury, not only the actual magnitude of force that goes through it. So we'll talk about that a bit more in a second. So this is where, just coming back to the increased ground substance in the tendon. So tendon that is, the funny thing about tendon that is energy storage, like Achilles, is that it has more ground substance, which means, and the ground substance makes it viscoelastic, and people would have heard that term, viscoelastic. So elastic is if you have an elastic band, which is basically like a pure spring. Any viscosity or resistance to that spring function is why we call it viscoelastic, because there's the water that basically binds to the collagen, and that creates resistance to stretch. So when you load a tendon quickly, it's much stiffer, and that's because of the viscoelastic properties, and that's a protective mechanism. So that's probably why that happens, because there's such high loading rate here that it just tries to protect the tendon from injury. But obviously it doesn't completely work, because we still get injury. That's probably because of various factors like doing too much, the type of how that sort of stretch, shorten, cycle load is implemented. There could also be a change in the interaction between the fluid and the collagen over time. So if you do lots of running or lots of hopping, this protective mechanism is not there anymore to protect you, and you start to get loading of the collagen and overloading of the cells. So there's various things we don't really know fully, but there's I guess an idea about why stretch, shorten, cycle loading is more likely to lead to injury. So that was really just a bit of a preamble of, I just wanted to set up how the Achilles is a bit special and how it is a high loading tendon and an energy storage tendon. I'm now going to turn to more clinical stuff in terms of physical function capacity. So in the clinic, how can you measure the function? What can you do to assess Achilles tendon function? Well, simple things like calf raises are actually quite good. So looking at a calf raise test for endurance, tempo 2 to 3 seconds up or down, up and down, making sure you've got good plantar flexion range. The thing you want to do is make sure the technique is good. So a lot of people, if they're weak, will do things like this, where you can see this guy is swaying to the point where he's really not loading his calf very much. He's just hinging into sort of knee flexion. So these are the types of things that can make something like this quite challenging to have good technique if someone is very, very weak. The other thing you see is rolling over onto the lateral side of the foot. Okay, so again, that's going to really load the perineal muscles and some of the other structures around the ankle. It's not really going to load the calf at all when this person is doing this type of calf raise. Okay, so so we can improve, and we should be looking at technique and doing things properly. How many calf raises should someone be able to do? If you haven't seen it already, have a look at this paper. This author here is quite, she's done a fair bit of stuff in Achilles tendons, and she's got some really nice papers. This one here is just I guess you could call it a normative data study, where she's taken a big group of people and looked at various ages and seen how much calf raise strength. So I'm 46 years old. I should go to calf raise 28. I definitely can't do 28, but that gives you an idea of, are you at the right level, and is your patient at the right level? Okay. A lot of patients in their 80s struggle to do 10 calf raises, and that's probably the ones that come and see us, obviously, because they're the ones that have got issues. But it gives you an idea, where do you need to get them to? Okay. So a good paper to also give to patients to reinforce that. The other thing that's quite useful in the clinic, physical function capacity, is looking at the, sorry, that should say seated calf raise, looking at seated calf raise. So we do this in a Smith machine, but you can also do it in a seated calf machine. It's just a bit more awkward and a bit more difficult, depending on how good the seated calf raise machine is. But generally, what you want to do is an 8RM. So 8 repetition maximum is just a multiple repetition maximum. So everyone's heard of 1RM, which is how much weight you can shift in a certain movement one time. A multiple RM is when you've got basically how much weight can you shift for a certain number of RM. So I generally would do an 8RM, where you want to start on around about 80% of their body weight on the bar. And then you want to basically just see, with good technique, can they do 8? If they can do 8 easily, give them a 2-minute rest, and then go to the next level, which would be maybe sort of add 15-20% to the bar, and keep going up in that fashion until you find that they can just do around about 8. Okay, and they fatigue after 8. So that's sort of how you do an 8RM. It's a really, really, really good strength measure. I like it because it applies to, it applies directly to your, you can use that as a rehab exercise. You can use it to motivate them. Often you find real big differences side to side, or even just weakness generally. So the person who should be talking about this is Igor, who's hopefully listening today, but he's got a paper that is currently under review. I can't remember what journal it's under review with, but it's a big case control study, and he's showing that there are differences, particularly with the seated calf raise, between recreational runners with and without Achilles tendon problems. So, and that will be hopefully something that we can use to guide us with what we want to be targeting. Okay, so that's a really good test. The other thing that you can do in the clinic is hopping. So with hopping, you want, you think about hopping as a sort of spring mass model, where you've got your body bobbing up and down on a spring, and you're just basically just going up and down. And that's different to running, where you've got more of a sort of horizontal component as well. But so basically with hopping, the maximal forces are going to be in this mid-stance position, and there's quite a few things you can do. Really, the thing to understand about hopping is that it does tell you something about efficiency and power. So this is really good study to look at if you want to understand submaximal hopping. So basically what we're looking at here is hopping frequency. So generally hopping frequency for humans is about 2.2 hertz. That's the natural frequency that most people hop at. And this is now vertical stiffness. Okay, so you can see that the instructions really matter. If you get someone to hop as high as possible at a certain frequency, they need to use more vertical stiffness to do it. Whereas if you get someone to hop in whatever way they want it without maximizing height, their vertical stiffness will be lower. And not only will their vertical stiffness be higher, but also their contact time on the ground will be lower if you ask them to hop as high as possible. So you're making them more efficient at a given hopping frequency. And that's sort of the idea of hopping, to make them more efficient, be able to produce more power, spend less time on the ground, more time in the air. And that's going to come down to rate of force development, really good strength. So generally with hopping, the way that I think about it is decreased contact time at the same frequency. You're going to be more efficient. You're going to have more time in the air. You're going to have greater jump height at a given frequency, okay, of hopping. So that can be quite a useful thing to look at. Some people are quite good at hopping, quite efficient. And you're sort of looking at how much time they spend on the ground, how much time they spend in the air, and how high they get. But certainly with Achilles patients, we do see patterns where they're spending a lot of time on the ground. A lot more time on the ground, they generally have got less efficient patterns. That's his unaffected side. See, the affected side was not as good. But obviously this is a very clinical thing. How can we make that more objective? Well, to make it more objective, what we need to do is just measure hopping if we can. So if you're in the clinic, you haven't got much equipment, just use apps like MyJump. So that will give you at least maximal hop height. So if you get someone to hop it's like a pogo hop, where you get them to hop at 2.2 hertz, but as high as possible within that frequency, you can see how efficient they are. You can measure their maximal height. That's giving you a measure of power. Or you can invest in a force plate. This is the force plate that we've got in the clinic now, and it basically measures just the forces, but you can then use programs to work out things like contact time, flight time, vertical stiffness, etc. And they can be quite useful. I don't use it with patients because it takes a lot of time, but we do have, so for example, next year I've got a honours student who's going to be in the clinic, and because I see a lot of Achilles patients, he takes the Achilles patients aside and does a series of measures with them. So that hopefully we'll get some measures on people, starting to collect some data as of next year to understand these changes a bit more, because it's really, no one has looked at this in any great detail at all. So it's really just learning about what the impairments are and if they change with rehabilitation that we're doing at this stage is all we're interested in. So just quickly, I'm not gonna talk for too much longer, but I just wanted to finish off with so we've talked about the Achilles and how it's a very strong and powerful tendon. Then we've talked about the assessments of how you can assess some of the power and strength components of it. I'll just finish off by talking about the force velocity curve and how we can use that to implement some of our rehab. So this is an example. It's probably from a JB Marin paper. I think I've taken it from, but looking at sprinters and the types of things that you might do with a sprinter in that force velocity profile. So we know there's a trade-off between force and velocity. You can't do things with a high force if you're doing them very fast. Just haven't got the time to develop that force. But you can develop a lot of force if you do things slowly. But you do want to train people in different parts of the force velocity curve. And this is not just athletes, it's anyone. So even if I see a walking patient with Achilles tendinopathy, I'd still want to do something that is speed or power. And if you've got an athlete, a runner, you'd want to do some. If you've got an elite athlete, then you want to do even more. So regardless of the patient you're looking at, you do want to do stuff, maximal strength, things like, heavy squatting and deadlifts, strength speed. So the prowler or the sled pushing can be quite good. Speed, strength, sled sprints. Now, you'd only really do this with sprinters and more high-level athletes. I don't do a lot of this, but I would do a lot of this stuff and then moving on to plyometrics. So generally, the way that I would think about tendon rehab is in 3 periods. So if you want to periodize it, it'd be 3 periods. The first one is isometric and just building strength endurance. And that's when you're building the motor patterns, you're getting them used to the exercise, you're getting them used to doing the movements that you want them to do. Isometrics if they're very painful to start with. Moving on, so then maximal strength and strength speed. That would be the next phase. And then the last phase would be plyometrics and power. So converting that strength to power. Now, I often start plyometrics a bit earlier if it's submaximal. If it's really submaximal, you don't have to, but the maximal isometrics, you do want to wait until they've got maximal strength, because otherwise they can't really jump or hop maximally until they've got maximal strength. So there is a progression there, but with some of the submaximal isometrics, you can start earlier. So thinking about just quickly then, just to finish off with the rehab, and just talking a little bit about some of those phases. The isometric rehab, you can do things at home. So this calf wall sit is quite good for home. The standing calf raise hold is quite good for home as well. You can do things in the gym. So sit a calf raise hold if you've got access to it. Leg press hold if you've got access to it. And I've just got some indications of how much weight you might get to. So body weight, they can hold half their body weight. So, I do have people holding 20, 30 kilos, 40 kilos in backpacks and various combinations of backpacks and dumbbells. Similar for the standing calf raise hold. These ones here, obviously you're non-weight bearing, so you haven't got your body weight. So you need to then factor your body weight in. So you put your body weight and then you put pretty much the same amount. So going up to sort of half body weight additional to that as well. So generally work up from 10 to 30 seconds, 5 to 10 repetitions. Generally I'd get them to do this once a day. And the work-rest ratio can be quite low in terms of rest, because you're not really getting a lot of fatigue with this, and you can just roll in from the right to the left and then just keep going. The intensity needs to be up there though, and obviously you want to build that in gradually, because you can sort of flare them up a lot if you build the intensity in too quickly. So build the intensity. Now the intensity scales that I use are the Omni scale or the reps in reserve. I'll just show you the Omni scale briefly. So this is a really good option for strength and any rehab when you're trying to judge intensity. So looking at, and just look up the papers, there's really good papers on the Omni scale. It's designed for strength and resistance training, intensity, and basically anywhere between 6 or 8 out of 10 is going to be the type of intensity you want for tendon rehab, and obviously build into that gradually. Thinking about the isotonic rehab phase, so here generally standing calf raises, and then standing calf raises body weight, progressing into some weight and some load. Seated calf raise, similar to what we saw with the isometric, so you might go from one times their body weight to 1.5 times their body weight on the bar. Just be careful with it. Insertional people, you don't want to go into dorsiflexion, as we know. So here you're doing really the sort of strength endurance, what I would call strength endurance, so 8 to 12 repetitions, 3 to 4 sets, a little bit longer rest time. You can do this 2 to 3 times a week, this type of rehab. And again, you want to get up to pretty good intensity, okay? So that would be isotonic rehab, progressing to that. I guess the thing that people don't do as well is the maximal strength. And maximal strength is important. We know it's going to be critical for people to produce power. And you can do variations of this for, as I said earlier, most of the patients that you see, whether they're old or young. But you just need to bring it in gradually and do it when they're used to the things that they're doing and they've got the strength that they need to have. So repetitions 3 to 5, sets 3 to 4, work rest ratio is much higher because you're waiting for the nervous system to really recover with this type of maximal strength. And I generally would do it once a week. So if I'm periodizing, if I'm sort of doing 3 sessions of strength for someone per week, then it'll be one would be when they get to this phase, they'd do 1 maximal strength and the other 2 would still be strength endurance. The other thing that we've gone away from is eccentric training, but I'm starting to get back into it because I think it's a really good way to develop maximal strength. So once they're in this phase, you can then just bring in eccentric isolated. So they're going up with 2 legs, down with 1. And what that does is just allow you to get a much higher load into the system, and they get much better tendon and muscle activation adaptation. So it's a really good way to then build in some of this maximal strength. And the good thing is with Achilles, very easy to do in a Smith machine. Because you've got basically you can use the other leg to help you with the concentric. If you are going to do strength speed, if you've got access to it, you've got maybe a higher level person. For the Achilles, you might consider something like a sled push, where you've got, say, the sled plus the weight to make 50% of their body weight, and then you can sort of go up to their body weight. So they're moving slow still. So it's still more of a maximal strength intervention. They're not going to be sprinting by any means with that amount of load, but it allows you then to build power. Probably the most important thing with maximal strength and strength speed is to make sure that there's an intent to move quickly. So they have to move quick. And that is what is going to help their force velocity curve, which we saw earlier, to improve, okay, that intent to move quickly. Whereas these things here, there's no intent to move quickly. So there's no real improvements for rate of force development. But if you want to improve rate of force development, you've got to have an intent to move quickly, even if you're not moving fast, okay? And that will transfer over into power. Okay, so this is a bit of the Igor Sancho show tonight, but this is another one of his studies. And this one's published, and he's basically here we did a pilot feasibility trial where we looked at adding hopping into rehabilitation for Achilles patients, and we showed that it was safe. It was safe, and it was a good sort of additional thing to add in. It was just a single cohort, so hopefully we'll go on and do more with that. But this is the hopping program that I use. It's evolved a fair bit since Igor's paper, but the one I currently use is double leg 2 sets of 20. And I've graded them now as low intensity, medium intensity, high intensity. And there's 20 contacts of low intensity, 84 contacts of medium, 32 of high. So double leg jumps, single leg hops, double leg jumps with a stiff knee. So that's the stiff knee is what I was talking about earlier. It will encourage them to have more efficiency because it will force them to go higher with a stiff knee. So it was, just think about the Farley paper that I talked about earlier. Single leg forward and backwards hop, single leg side to side hop, single leg stiff knee. Now you're getting into high intensity. So this is a stiff knee. It's like a pogo jump as high as you can, but at a certain frequency. Single leg forward stiff knee, 2 sets of 6. So generally bringing that in gradually over the course of a rehab. You want to do it for at least 12 weeks, but you do want to start with low and medium intensity. This is just a video of some of the hopping. So double leg jumps, single leg hop. And this is just a natural frequency. They'll probably get a bit better, a bit more efficient. This is now the pogo jump. So you're now jumping with a stiff knee. So you try and keep the frequency the same. This is forward hops, and then going straight into backwards hops, straight into backwards, and then looking at sideways. So obviously this is a lot of hopping. So you don't you definitely don't want to put this program it into the same, do it all at once. You got to start gradually over a number of weeks. Then you've got, this is now the stiff knee hops. I'm not very good at hopping. Should be a bit stiff. It's not very stiff at all. And then forwards, stiff knee hops. That's the highest intensity. Okay. So that basically is pretty much what I wanted to talk about. I just wanted to finish off with, this is another PhD student systematic review that she published in Sports Medicine Open last year. And what we found in this review is that there really is limited evidence showing improvements in any strength power measure in the calf for Achilles rehab. We found no evidence, even though people have measured it, there was no evidence of improvement in power or strength. So when you're doing all the rehab that we're doing at the moment in the literature, strength doesn't improve, power doesn't improve. The only thing that we found limited evidence that it does improve is endurance. And that's probably because a lot of the programs that are out there at the moment are very much endurance based. So we get people to go home and do 3 sets of 15, whereas that's really not going to improve their power and strength. There wasn't many studies in the review that actually looked at it, so that's a limitation. But we do need to be better at trying to improve the strength and the physical function capacity of within Achilles rehab. So I will leave it there. Over to you, Dave.
Thank you very much, Pete. That was excellent. A very good summary. And just to, again, just highlight the Q&A function. So yeah, if you guys do have any questions, feel free to throw them up on the Q&A. We'll answer live if we can. And Pete's now available as well, so he might be able to answer a few live. But we can enter them all into the Q&A at the end as well. So yeah, don't hold back. Definitely answer those questions or ask those questions. I'll hand over to Andrew. He's going to head us off with some medical considerations to do with Achilles tendinopathy.
Perfect. Thanks, Pete. Thanks, Dave. So just quickly getting into what I was hoping to talk about. So the medical considerations, obviously we come at it from a slightly different view. And thankfully, realistically, I think Achilles tendinopathy should be managed by you as a group and hopefully using us just in those more challenging cases. So, and obviously we'll get to why that should be the case later on. Obviously the best evidence is for a progressive strengthening program. And I think it's really important when we are seeing our patients with Achilles tendinopathy, just to keep in mind the significant impacts it has on their quality of life. A lot of these people that we are seeing are generally really active. That's not the case for everyone, but a study from 2018 out of the University of Canberra talked about how the patients that have Achilles tendinopathy generally have lower markers of quality of living, and a number of the sort of key take-homes out of that was that people had to learn to adapt their lifestyles due to Achilles tendinopathy, and in such, that really had major impacts on their social well-being and their mental well-being, and dealing with conflicts of their identity and the frustration of having to deal with a prolonged pathology. And part of that is to up to 45% actually have ongoing symptoms, even with a good program. So what I think is important is if we are expecting that a reasonable proportion of our patients are going to be part of a prolonged rehab, that we do have a need to make sure that we are getting the right diagnosis for them. And look, still the vast majority of people that we see that can present with posterior heel pain or that sort of posterior pain will generally have, if they're stiff in the morning, if they have pain when they pain that warms up with a little bit of activity that then is sore post-activity, if they do have that focal tenderness and pain around that mid portion of their Achilles, and there is a history of load change or overload, then clearly the vast majority of those will have an Achilles tendinopathy. But if they don't, and if you do have some concerns about, whether this is a slightly different pain, whether it is a bit more medial, and whether there might be some plantaris involvement, or whether there is evidence of some posterior impingement or pain around the posterior ankle, then it is really reasonable to start looking at getting some confirmation of that diagnosis. And that's where some imaging can be useful. Obviously, we just want to be careful we don't overuse imaging, but there clearly is some good options for us. And these days, we are really lucky with some of our modalities. Point of care ultrasound now is so easy. I've got an ultrasound here now that is excellent. Like it gives great detail, and look at it careful that we are getting good ultrasounds, and part of that is making sure that people that are doing ultrasounds are doing a lot of them, and the point around that is that ultrasounds really are quite user dependent, and also it's sort of, as well as we want to make sure that if we are asking someone to do an ultrasound, that we are asking them for valuable information. So what I mean by that is, obviously, for instance, we look at a shoulder ultrasound. You don't need to look too hard, and you'll find some bursitis and a bit of tendinopathy in the shoulder. And what you really want to make sure is that actually aligns with their symptoms. So with regard to the ankle, if you are sending someone off for an ultrasound, you really want to make sure that you are asking that sonographer, what are the few little different differential diagnoses that you are concerned about, so that they can actually look for those individual pathologies and actually give you a reasonable report and confirmation of the pathology you are trying to treat. So I think ultrasound is really good in confirming a diagnosis, whereas MRIs should be reserved for those really challenging cases where there are other pathologies that may be even involving the rest of the ankle that need to be ruled in and out. The good thing is as well that neither of these modalities have radiation, and so we have so we're a little bit lucky there, as opposed to an X-ray or further CTs. What I did want to do is just show some really normal pathology and then some really obvious abnormal pathology, and just so when you are looking at any of your ultrasounds, as opposed to just looking at the report, just go into a bit more depth of what we are looking at and what you could also be looking at as well. So what this here is, I'll just be quickly through this. This is the normal Achilles tendon. What are we looking at here? This is the superficial, so skin, bit of subcutaneous tissue here, and then the Achilles tendon. And what we're looking at here is just really, prominent parallel fibers of the tendon, no sort of dark areas or what we call hypoechoic regions, which would be in keeping with tendinopathy, and generally a tendon thickness of around about a centimetre. So that's a very normal looking tendon, and that looks quite different to this sort of tendon, in which there is, it's not marked out, but this will probably be the proximal end up this end, and then you can see this thickening of the mid portion of the tendon, and then it tapers back into the insertion at this end. So that's abnormal. There's also some dark or black areas through this area here, so a hypoechoic change, and that is in keeping with tendinopathy. And so that's the longitudinal axis. And then if we look at that in cross section of the same patient, you can see this central core, as was demonstrated on that the longitudinal axis. And once again, a hypoechoic region, and that's also in keeping with tendinopathy. And then if we look at, once again, that same patient, there's sort of a whole confirmation of tendinopathy here. So this is looking at blood flow, and so the red and the blue blood flow is blood flow in different directions, and what we're seeing is blood infiltrating or new vessels coming from the anterior portion, or the anterior side of the tendon, and into that, once again, that tendinopathic region. So once again, just the full Monty on Achilles tendinopathy. We've got to be a little bit careful with of what these vascular changes really mean. You can have them in relatively normal tendon, but it can be a helpful marker of people's pain, and it is useful to look at, but you don't want to pay too much note to it. Another pathology this is the full Monty as well for insertional Achilles tendinopathy, so a really thickened tendon here as well. as well as having a hypoechoic changes in this portion, as well as having those new vessels. And interestingly here, you can see a calcific change at the insertion. So this is the calcaneus, the insertion of the tendon coming down, and then this calcific tendinopathy of that insertion. A couple of other quick pathologies. This is once again cross-sectional ultrasound of the Achilles tendon, relatively normal tendon at the superficial region. There is probably some hypoechoic changes here, so this does have a degree of tendinopathy. But what's the most notable feature here is this is the paratenon and the thickening, this black sort of shadow that is around it. And there may also be one down this side if you bring the probe over. But this is paratenonitis. And so what's important about this is obviously this can be treated hopefully with some anti-inflammatories to get that patient going really quickly and avoid a lengthy tendon program. Another one, retrocalcaneal bursitis. This is the insertion down here, Achilles tendon, and then a big pool of fluid in their retrocalcaneal bursa. So that's obviously something that we can look for and really quickly identify and move on with alternative treatments. Lastly, a couple of I just want to look at a normal MRI. This, the beauty of this obviously is we get a lot more information about that whole hind foot. And so, quickly looking at whether the bone looks normal, so whether there's any white in the bone or inflammation, so inflammation having a high fluid content, so it comes out bright in these studies. So whether there's any bone edema you might see. In this case, what is a really normal looking Achilles, there's no significant signal within the Achilles tendon. You could argue there's a slight thickening of the mid portion of the tendon, but really it's a very normal tendon, as well as the insertion. There is a little bit of fluid in the subtalar joint, which is normal. Also a little bit of fluid within the retrocalcaneal bursa. Once again, absolutely normal. A normal plantar fascia as well. Whereas this is a case of mine from earlier this year, and this was a patient that actually was bouldering and had a small little fall from less than a metre, and actually hurt their knee by hyperextending their knee. And then after the knee settled down, they came in with significant posterior heel pain. And you can see in this case, actually a relatively normal Achilles tendon, some slight thickening, but no significant signal within the tendon to concern you about an Achilles tendinopathy. However, they do have a significant retrocalcaneal bursa, as well as some interesting cysts within the bone. So, you just don't get this detail out of an ultrasound. And so what happened with this gentleman is he started on some anti-inflammatories, and with some further investigations, it actually turned out, he was very reactive. It didn't fit with a normal sort of Achilles tendinopathy or even an insertional tendinopathy. And ultimately he, with some further investigations, found to have psoriatic arthropathy or arthritis. And so that completely changed how we manage this person, as opposed to looking at sort of a tendon program. So just looking at some of those other pathologies that can really, that can masquerade and present as Achilles pains. And then what I wanted to talk about now is how, if we can identify some of these other primary pathologies that then can lead to secondary pathologies or Achilles tendinopathy. And if we can manage that primary pathology a little bit better, then we are going to make our jobs a whole lot easier in managing those tendons. So, as I said, my gentleman had psoriatic arthritis, which usually presents as an insertional tendinopathy, much like an ankylosing spondylitis. And then rheumatoid arthritis usually presents more of it as a tenosynovitis. So what I wanted to think about here is, if you find that you think a patient presents with a really reactive tendon, and particularly if they've got other joints that are involved or other histories of tendon involvement, then be on the lookout for whether this may be an inflammatory arthropathy. And not that we're expecting you to diagnose it, but just be thinking about it so that we can potentially refer on to your GP or to your sports physician, so we can go about some appropriate investigations and actually identify any underlying cause, and then hopefully make, as I said, the management of the tendon a whole lot easier. What I think why I really wanted to talk about this in particular is that I really like thinking about ways that we can change the outcome for our patients in the short, medium, and longer term. And so, just for reference, people that are diagnosed with ankylosing spondylitis, the mean time between onset of symptoms and a diagnosis is actually 10 years. And so if you do see that person, that, you know, that typical young male who has a history of some insertional tendinopathies and a history of back pain, then if you make that call and if we do some simple investigations at that point, we can really have a huge change on that person's outcome in terms of developing osteoarthritis and modifying their disease in the longer run. So once again, just think about, if you do see those patients, refer them on, GP or us, and we can do some really simple blood tests at that point. We do some screening of, you know, things like CRP and ESR, which are just basic inflammatory markers, as well as some slightly more specific markers, looking at individual diseases like rheumatoid arthritis, as well as some general screenings. And then if they turn up with anything in particular, that gives us an opportunity then to do even more targeted screenings. We don't do those targeted investigations all at once because it can be really expensive if we do that. And so we do go through a bit of a stepwise fashion. If we do find those and some of those turn out positive, then we will proceed with some further investigations, such as MRI of whatever that area is. So in this case, obviously the ankle, but also X-rays of other areas, such as in that young male, we'll be looking at X-rays of his sacroiliac joints to see if there's any changes of sacroiliitis, and that has a huge impact in terms of obviously what staging his pathology and disease, but then also looking at it can change the medications that he may be, or particularly he may be eligible for in the longer run. So that can be really helpful. We'd also be looking at starting initial management, so anti-inflammatories of some sort, and they may be non-steroidals, but it also may be steroidal anti-inflammatories to see if they respond and get their underlying or get their musculoskeletal pain under control, and start them then looking at doing an exercise program if that's appropriate, and then also looking at and making the appropriate referrals to a dermatologist or a rheumatologist if that person's looking like they need to be considered for disease-modifying agents. Other pathologies that I think we should be on the lookout for, especially with tendinopathies, is diabetes. And once again, it's that whole sort of making a difference for your patients. And what I like about this is, you know, we have the understanding that diabetes and some of the other pathologies I'll talk about in a second do impact on other body areas, and in particular some of the musculoskeletal areas. And what we can then do is hopefully even improve their management of their underlying condition by making those links to some of their musculoskeletal concerns. So I think some simple questions that you can ask, in particular, the one I really like is, what level of control do you have of your diabetes? And the one you need to be thinking about is, what is their HbA1c, and when was it last done? And if someone can answer that really cleanly and clearly, and know when it was done, and know that it was within normal limits, then their blood sugars are probably pretty well under control. So what you're looking at there is, for someone with diabetes, probably good management is between 6.5 and 7, and it should be done within the last 6 months. If they don't know the number, if they don't know when the last one was, that's a perfect opportunity then to hook them back in to see their GP, and then also look at, and hopefully that GP will then look at whether they need some further education. Do they need to have their diabetes just modified and improved a little bit? And ultimately, once again, we're looking at how that's going to make a significant improvement for their underlying tendinopathy and make our jobs a whole lot easier. And I think the other thing just to keep in mind why this is so relevant is that 1.8 million Australians have diabetes. 500,000 of those don't know they've got diabetes, and 1 person every 5 minutes is diagnosed in Australia with diabetes. Some of the other things that I'm always, considering when someone presents with a tendinopathy or tendon pain are whether they have had some fluoroquinolones in the past. So the fluoroquinolones are a number of antibiotics that can cause really reactive and painful tendon pains. Those three there, ciprofloxacin, norfloxacin, and moxifloxacin, are 3 that are commonly used in Australia. Ciprofloxacin is used regularly for things like traveller's diarrhea. It is a wide spectrum antibiotic, so it's used reasonably regularly. Norfloxacin is a really good antibiotic for urinary tract infections. So generally our older population may be looking at using those, especially if they've got some prostate issues. And moxifloxacin is a gastrointestinal antibiotic. So I think one of the key points around fluoroquinolones is that people will either present anywhere, it's the rule of sixes, between 6 hours and 6 months after they're commencing their fluoroquinolone, but generally at about 6 days. And so where you can be really helpful is if someone presents to you with some tendon pain and they've just recently started an antibiotic, you need to be thinking, well, I think I need to get them back to their GP or whoever started that antibiotic so we can stop that antibiotic and then look at alternative options that person can use that won't hopefully have those negative impacts on their tendons. Next medication that's really important is corticosteroids. And so not short-term use, so not a 10-day course for, say, back pain or radicular back pain or some other, respiratory condition, but more the prolonged use. So thankfully we don't have as much of this these days, but essentially what it boils down to is it leads to some microvascular changes which can make it obviously our challenge of dealing tendons even harder. And in terms of microvascular changes, that also applies to hypertension as well as smoking. So once again, it's about feeding back and hopefully, drawing those links to your patients about the fact that their hypertension, if it's not really well controlled, will lead to some microvascular changes, which will then make our challenge harder to deal with that tendon. And so if we can get their blood pressure under control a bit better, then that will have a positive impact. And obviously any other chance we get to reduce people smoking is perfect. The final one there is dyslipidemia. And this is an interesting one. There is a group of patients that have familial hypercholesterolemia. They do get fat deposits in their tendon and can be really problematic tendons. But just in general, anyone it's a correlation between the higher levels of hypercholesterolemia lead to a correlation of severity. So increased levels of cholesterol lead to increased severity of tendons. So once again, just be mindful that if that patient does have a history of high cholesterol, that if we can get that under control, we're hopefully going to have a better outcome. And so finally, I just want to quickly talk about some other reasons why, or some adjunct options that we have in terms of managing those trouble tendons. So GTN is something that's been around for a heck of a long time. So one of the first studies was back in 2004. And interestingly, had a really sort of pretty positive outcome in terms of pain scores day and night pain at early stages, so at the 3-month mark, as well as improvements at the 6-month and in terms of day pain, as well as some improvement in function. The big challenge with GTN, however, is people get pretty prominent headaches, and a lot of it can be managed with Panadol, but there is still quite a few that need to pull out and just don't tolerate the headaches that they get with it. In saying it, it's not all perfect and good outcomes in terms of GTN. There's a more recent study from 2018 which showed that in a group of 20 that either had GTN or not, there was really no change at the 3-month mark in terms of pain scores. And interestingly, the reason we think that, or the reason that was proposed in terms of GTN is that the nitrates lead to an increased blood flow in the tendon. And interestingly, there's a group of those patients that were on the GTN patches that ended up having surgery and had some of their tendon taken and sent off for sampling, and basically there was no increase in those nitric oxide isomers there. So maybe how it works is not so well understood. And interestingly, about 15% of people had to pull out due to their headaches. So shockwave therapy is an interesting one. So once again, how it works is still, up for debate, whether it's an inhibition of the afferent pain receptors, or which is more of an acute response, versus whether there's the trauma of the shockwave therapy leads to some biochemical changes, in particular release of growth factors, as well as potentially some neovascularization. So depending on what reason you're using the shockwave for, I think there are options to use it. So interestingly, I do use shockwave, but I don't use it so much for the biomechanical changes. I'm using it more for the modification of pain that it can achieve. So like just today, I saw an elite athlete who we did shockwave on for a patella tendon, and then they went off and did training and that training that shockwave is hopefully modifying their pain, and they're finding that it's improving. They're able to achieve more in their training sessions and their strength sessions. So that's where I like it as a modality. But actually, of all the adjuncts I'm talking about today, it's probably got some of the better research behind in terms of success, albeit it's not all rosy outcomes. Anti-inflammatories, so obviously there's a number of patients that come in with really reactive tendons, and look, I think anti-inflammatories can be really useful, just really mainly as a short-term modifier. So we don't want people on them for a long-term. Obviously there's some significant side effects that we need to be considering, especially gastrointestinal, which are the most common. But the more concerning ones are the ischemic heart disease, the hypertension, and the asthma. And in that older age group, we really are looking at a short-term burst of, say, 7 or 10 days, sort of as a maximum, and seeing if that short-term little burst can then allow us to get some more load into these patients. I think it's also important to keep in mind that there is quite a variable response between patients of different anti-inflammatories. So just if someone has tried something like a Nurofen and it hasn't worked, I still would be trying to use a different type of anti-inflammatory depending on their side effect profile, and seeing if that has a better response for them. Triple therapy is another interesting one. This was proposed by a couple of Australian prominent sports physicians as well as physiotherapists, and really it's a theoretical paper that didn't look at a number needed to treat or a group of patients and comparing them against a control group. But what it was looking at is looking at some of the reasons and some of the pathology behind tendinopathy, and looking at those individual changes that occur, and I've got them at the bottom there, and then looking at some of the medications that may actually target that. And so this was proposed back in 2007 and really took off around that time. And even at the time I was a registrar in sports medicine, it was still really being regularly used. It's something that's died off of more of late. However, it still is reasonable and it still is safe to use. There's a patient of Peter in mind that is using doxycycline, and the reason that Peter sort of, when he took history, he found that patient was really asymptomatic. Basically, he worked for the Defence Force, and when he was away and taking doxycycline as an anti-malarial medication, he really had minimal symptoms. So that was one reason why we looked at using it. And from what I understand, he's doing reasonably well, but I'll get Peter to fill us on if that's any different to that. There's also times in patients where they're really sensitive, and there is, we've got to keep in mind these can be some patients that have had persistent symptoms for a long time, and the pain is no longer a simple, the pain is no longer a helpful stimulus for them. And so, look, these generally patients who have not just Achilles pain, but pain in multiple other areas. And I commonly use medications, neuromodulators such as MDEP and amitriptyline, or Lyrica, as something to try and modify and reduce some of the sensitivity of these patients. They do have their side effects, and it does take a reasonable amount of counselling to start someone on these medications, and then really a very tapered, slow increase in dose. But because a lot of the side effects can be profound, but they can also use some of these side effects to make a difference as well. So people tend to be drowsy after taking a number of the medications. And we can actually use that to improve sleep if that's been a problem for the patient. So that can be really helpful actually, and actually get a lot of their pain under control. But once again, I only do that if there's when we're using a lot of pain education and looking at multiple other educators as well in that field. PRP, now this is, how does this work? Well, that's another good question. Look, the main proposed theory around this is that we're concentrating a number of the growth factors within platelets, and hopefully getting a magical concentration of growth factors within that tendon. Or maybe it's because we're causing trauma and causing a stimulus to the tendon. However, the more I look into PRP, the more I can be honestly a little bit disappointed. There's a number of case reports that are really positive about the outcomes of PRP, but if you look at some of the more recent RCTs, there really is, it's hard to draw any conclusions that other than there's really very minimal benefit of PRP over placebo. So 3 recent ones. So Kearney had a PRP versus sham of 240 patients in which they found no difference at 6 months. De Jong had 54 patients of PRP versus normal saline, and they had no difference at 12 months. And then Crow had a study of only 24 patients, but it once again was looking at PRP versus normal saline. And in that group, they had no change at 3 months. So you've got no change at 3, 6, and 12 months. So it is really hard to use this regularly. People that would support it would suggest that the PRP that isn't working is because it's not done correctly. And part of the limitation of research regarding PRP is that every PRP is slightly different. So the PRP that would come out of my body is slightly different to the PRP that would come out of your body. And the way that we prepare it can alter whether it's leukocyte rich or leukocyte poor. And so the proponents of PRP would suggest that it's not, the PRP that we're producing isn't PRP rich. I'll leave that up to you. But look, I still use it. I have to be honest about that. It's just that I don't use it very often. And it really have to be careful with the group that we are using it. And I have to make sure that they are doing a really good strengthening program as part of it, because PRP alone clearly won't do the job. One thing you've got to be really careful about is a pain flare. So you really don't want to be doing these in reactive tendons. I've had one and it was a real challenge for the best part of a month to get that person back to square one. High volume injections are one that I do like and do use a bit more often. And the mechanism of why we think this is helpful is we're trying to target that. So if you think back to that ultrasound with the blood flow into the tendon, we do think that infiltration of blood flow and associated nerve fibers cause pain. And in trying to basically obliterate that blood, those vessels. And so what we're filling up is a relatively large volume, so around 50 mils generally of normal saline, as well as some local anesthetic, as well as generally some corticosteroid into outside the tendon, but really close to the tendon and under ultrasound guidance, and basically filling up that whole area. One study by Van der Vist found that doing it without corticosteroid had really no benefit in terms of outcomes at the 24-week mark, and that was in a group of 80 patients. And then you might see the bottom one with which Peter was part of had some improvements with corticosteroids at each marker of 6, 12 and 24 weeks compared to placebo. I would note here that Peter will hopefully talk about this later, but he's also doing another sort of follow-up to this and looking at all the way to the 1 year mark. The one concern that I do have around this is regarding ruptures, and we've just got to be careful, obviously, around any corticosteroids around, in particular, lower limb tendons. And this was brought home recently where one of my colleagues had a patient with a partial rupture at the 6 week mark. You know, is that because of the tendon? I don't know, but is that because of the corticosteroid? Not sure, but I think you have to assume there may be a role. Last two, so tenocyte cell implantation and stem cells. Tenocyte cell implantation was something that was happening when I was a resident back in 2009 over in WA, when there's a lot of research going on to it there. What the process is taking some healthy tendon out of the patella, then multiplying it in the lab, and then re-injecting into the associated tendon, so the Achilles tendon. Now, what I would say, both, and a similar process with stem cells, but different tissue is the original tissue. Ultimately, all of these studies have a really high risk of bias, and a good part of that is regarding financial incentives to if these do turn out to be beneficial. But what it is clear is most of these, almost all of them, have a really low level of evidence. And at this point, it is pretty clear that they shouldn't be recommended for regular clinical practice, and that they should be used as really only in research, good research studies. The final thing that I want to talk about is a very small group of patients that may end up having to go to surgery. This was a study in 2016 that looked at a huge variety of different surgeries. Now, there are so many options here that it's really hard to group all these together. This was a systematic review of over 20 studies, and I think it's interesting they found that patient satisfaction was around 80%. Now, knowing a bit about some of the surgical studies, that threshold is of what is patient satisfaction can be pretty low, and so I'd just be mindful that really this isn't an option for most patients. This is just for a very small group of patients, and the only thing I'd say about it is that complications seem to be less in the minimally invasive surgeries than the open surgeries. And so I probably could have saved a bit of time that last little sort of with those adjuncts and just sort of talked about this study, which was a systematic review of 13 randomized controlled trials and looking at 528 patients, in which they found, unfortunately, that there was no significant evidence of any remarkable benefits provided by any of the therapies studied. So that's a bit concerning for me as a medical profession looking at tendinopathies. So when might you look at using us? Well, I think where we can be of use is probably as a sounding board. So if you are concerned about a diagnosis, you're not sure that this is a tendinopathy, then hopefully we can be really helpful in that stage. We can maybe do imaging at the time or look at some more appropriate imaging. If someone's failing to progress or failing to buy in, then I think we can be really, as I said, a really good sounding board to reassure the patient that they're doing the right things and that the timeframes are 3, 6, 12 months. And that if we continue to build their capacity within that tendon bit by bit by bit, that more than likely they'll have a really good outcome, but that it takes time. And that although that we won't do a lot of interventions and hopefully not early, that we can look at some interventions when someone's been doing a really good job of their rehab and still isn't having the outcomes that they're hoping for. So yes, finally, ultimately a prolonged treatment, really important to get that correct diagnosis. If there are comorbidities, make the options or make the referrals back to GPs or to us to help manage that underlying pathology. It's all about the rehab. And then if at the very last they are failing to succeed, we'll have a look at them and offer some adjuncts if needed. So thank you.
Excellent. Thank you very much. It's a very weird feeling finishing a talk on a webinar, isn't it? You're usually waiting for the round of applause, but both of you just sitting there quietly. That's great. No, but thank you very much. I think very good summary from both of you. We have got a few little questions. I think Pete was able to actually field a few while Andrew was talking there as well, but we might actually run through a couple of those as well, just so everyone can hear some of the answers. And if you do have any questions for Andrew as well, while we're maybe going through a few ones that were directed to Pete, you can start to write out a few for Andrew to field as well. Just to start, Pete, we had one question just about management of partial Achilles tendon rupture. So do we recommend patients to wear cam boots with crutches in these particular patients?
I think the issue is, what do we mean by partial rupture? I think Andrew alluded to the trial that we're running at Olympic Park, and we've recruited so far 130 out of 192 people with Achilles tendon pain at that mid portion. And one of our exclusion criteria is partial rupture. And getting some consensus with the radiologists and the ultrasonographers at Olympic Park has been difficult, let alone getting consensus with everybody. So it's a really poorly defined term, partial rupture. So to me, partial rupture, if you've got an acute incidence that has led to some very major change in pain and function, that's probably a partial rupture, I think. So if you've got something like that, as opposed to a scan where you've got a partial defect or some defect that looks like a tear, because that basically can be just completely just not relevant at all. I think that's the first thing. But if you do have one that you think is a partial rupture, if they've got a lot of pain with walking and you're thinking, this person just really can't walk at the moment, then a boot is not a bad thing. It's probably quite a reasonable thing to do for a while. But you certainly don't need to put them in a boot for an extended period of time like we do with a full rupture. Full rupture repair, obviously, you can do either conservative or you can do surgical treatment. Conservative treatment really is putting them in a boot for a few weeks, and that you don't need to do that with a partial rupture. It's just really symptomatic treatment because you're not expecting a lot of healing to go on, like with a rupture, full rupture. There might be some, but we sort of don't really fully understand how much healing can happen. So I think for me, it's more about just symptomatic treatment. You might put them in a boot for 2-3 weeks or something, just as they're really painful. I don't know if you want to comment on that, Andrew, at all. Partial rupture.
No, I agree with that. I think if you are comfortable that it is just a partial rupture, then short-term offload to just settle their initial pain and then get them loading again. If it is a true partial rupture, I'm always a little bit concerned when I read, if you hear a story of a partial rupture, that it's not a complete rupture. They're obviously much more likely. And then the only thing I'd say, if you do see a full rupture, get that person. The studies that look at managing people conservatively all get people into Aquinas really, really quickly. And if people are walking around for a week or so on their Achilles tendon that's ruptured, then I do get worried and concerned about whether there is that separation, and then obviously the long-term complications of having a sort of a defunctioned Achilles tendon. And
there was a question about that. There was a question about an over-lengthened. So with the ones that are left a bit, you can get this sort of over-lengthening of the Achilles tendon. And that does become a real nightmare because then you just don't get the function of the Achilles tendon back, and the calf just doesn't work the way that it should. I've had some real hard ones to rehab where they just cannot do a single leg calf raise for months and months and months and months.
Yeah, and they're the ones that if they end up in surgery, they're the really challenging. They're the tendon transfers that are really, oh yeah, you would hate to go through that rehab.
While we're on the topic of Achilles tears, we did have another question just on the impact of smoking to do with sort of the conservative or non-surgical management of an Achilles tear, and does that affect it? So would you potentially, if there was a heavy smoker with an Achilles tear, would you be recommending surgery over a boot protocol, or would you still be happy to go down the non-surgical route with someone like that?
It's actually more likely to go down the non-surgical pathway. So ultimately, there was a Cochrane review on this that looked at rates of re-rupture and following conservative management versus surgical management. And ultimately, the numbers are really, really similar. The main difference between the two groups is in terms of complications, in terms of wound infection, wound breakdown. And so the group that had a much lower complication rate was the non-surgical group, and ultimately smoking and diabetes and older age are the group that get the complications of the wound complications. So realistically, if you're a smoker, you're probably going to be looking at non-surgical management.
Excellent. We had just a quick question there on the dosage of green tea, I think, in that triple therapy.
Just lots, heaps, keep drinking.
Yeah, I think it's quite a lot. So yeah, I think someone suggested it was something like 7 or 8 cups a day. Yeah, so yeah, quite a few. So not particularly practical for a lot of people, I'd say. All right, what else do we have there?
Do you ever use the tablets, Andrew?
No, I haven't, but yes, that would be a good option.
That's a couple of patients have used tablets, which is a better idea.
More achievable.
Yeah, definitely.
Quick question there, just on rest between sets in loading, different loading exercises, Pete. So how do you determine the rationale between, I suppose, rest between sets? Is it just a sort of a self-determined thing? Is it something that's based on sort of any specific research?
Well, it's I just base it on resistance training principles. So if you look at, there's a really good review by Bird et al., which I did forward into the, I put into the comments there. But if you look at that review, it was in Sports Medicine 2015. 2005. And they talk about the different types of training that I've talked about there, which is endurance and then going into strength or hypertrophy and then maximal strength and then power. With power, generally, you are exhausting sort of nervous system mechanisms because you're getting maximal activation of the muscle. So you need to rest for longer if you're doing power type activities. But with and maximal strength type activities, if you're doing stuff like hypertrophy, there's actually evidence that resting for less time for strength endurance is okay and potentially even better, because that sort of partial recovery leads to better adaptations of your strength in that sort of phase. So it's worth reading this paper. I've put it in the, I think I've linked it there with PDF.
Yeah, very good.
Yeah.
We had a quick question there just put up about footwear. So on footwear recommendations for Achilles load management, so in particular for runners. Was there any styles or forms of footwear out there that is sort of potentially better recommended for people with Achilles tendinopathy to reduce load? Or in particular, I think she's recommended or suggested Hockers there seem to claim that they can reduce overall lower limb stress. But wondered if this was sort of based in any sort of research at all.
Not anything that I've seen specific, but my recommendations are just to patients generally make sure you're wearing very supportive shoes. I had a patient, when was it? Yesterday, who came in, very obese guy, 120 kilos, Achilles problem, diabetes, so probably one of the ones, like touching on some of the stuff Andrew was talking about, diabetes, hyperlipidemia, hypertension, he's got coronary stents, just a really difficult patient, cannot do a single leg calf raise because of his body weight. He was wearing flat shoes, which he's wearing flat Skechers. So advised him to go and buy, or go, I usually say, go to somewhere like the running club, running company, or sort of some other running place where you can try different ones on. The only advice is you got to wear something with a bit of a pitch, so it's got to have a pitch to it. As long as they're comfortable, they've got a bit of a pitch. I always use, well, not always, but many of the patients that I see will get orthotics as well. In terms of, when I say orthotics, I mean heel wedges. So there was the trial from Shannon Munson at La Trobe Uni last year. I think the lead author was his pediatrician, Chantel Rabusin, who's probably the best person to answer this question because they're all podiatrists. But they basically, use the clearly adjustable heel wedges. So I don't know if people have come across those, but they're very, very, very good heel wedges. So since we did that trial, I've used those for the last probably 3 years with Achilles patients, and I found them really good. They are quite expensive. They cost $50 for a set of 2, but they're very, very worthwhile. They're really good heel wedges. So that combination of shoes and heel wedges. So someone like that, a patient like that, he's got so many factors, risk factors stacked up against him that possibly, and exercise is going to be quite hard for him, possibly the heel wedges and the shoes are going to be the best thing for him in the short term to help his pain.
Had one question there on just the management of a paratendon or a paratendonitis there, Andrew. So what would your choice of anti-inflammatories be in that situation?
Yeah, so look, depending on how they're going, look, it is pretty easy to do a little topical treatment. You don't have any of the real side effects of the anti-inflammatories. So an anti-inflammatory cream such as a Voltaren, Hydroid cream, and then wrap it up in some Cladrip. Just got to be careful about irritation of the skin. So if that person does have really sensitive skin, then maybe they're better to go with an oral agent, such as just a pretty standard anti-inflammatory. But yeah, that can be really good. Some icing is also helpful. But yeah, a couple of nights in a row and usually that's a good change in patients' outcomes.
Mm-hmm. Do you continue to use isometrics once you've moved on to isotonic or power-based treatment, Pete?
Oh, that's a good question. I think you've got to ask yourself the question: why are you loading? So you can use isometrics for so many different things aside from just the entry point to rehab. And I think going back to the question about the over-lengthened Achilles tendon, one of the ways to overcome that is to do isometrics in that inner range position. And that works really well for gluteal tendinopathy when you want to avoid compression. You do it into hip abduction, isometric. So there's lots of uses for isometrics. Developing function in specific ranges, isometrics is probably, that's what it really is designed for. So if you've got a weakness of a patient in a specific range, you want to use isometrics. So you can use it throughout the whole rehab for certain patients if they've got deficits or impairments in their strength in certain ranges. And certainly a lot of the Achilles patients will struggle to lift. So like this guy that I've just talked about, this obese guy with mid-portion Achilles, he's always going to struggle to lift his body weight, and he's going to have an inner range deficit because of that. So then you would do double leg inner range isometrics throughout the whole rehab just to supplement the other stuff you're doing. So you could use it like that as a functional intervention. You could also use it throughout the rehab if you wanted to just help with pain. So some people, they're still struggling with a little bit of pain during the rehab. So you can use it as almost like a primer, trying to get their sort of pain down, and then starting to do their isotonic afterwards. So you can use it, you can mix it up for pain still. Yeah, so there's definitely uses of it over and above just the start of the rehab.
Very good. Tim and I were just chatting sort of partway through, actually, when you brought up your slide on calf raise norms, Pete. And we were struggling to think of too many patients that actually could reach any of those norms. Just wondering, for interest's sake, who are these things tested on? I actually had one of my friends actually who's listening in as well, who will remain nameless, that also said that he would get nowhere near that. And I think he can now understand why he tears his calf all the time. So
you're making me feel much better. I don't feel as inadequate now. But I think it's a pretty good paper, and there's quite a few people in it that she had, like 1,000 people or something. So I think it is pretty good. There was talk, Rod Whiteley emailed me once years ago and said we should do a study where we look at calf strength in all of our patients, because it probably isn't at that level. In a clinical population, it is going to be lower, because you're going to just because of the fact that it's a clinical population. But I think you're right, it probably is going to be a lot lower in the people that we see. But it can be a good motivator. But it's that, yeah, you want it to motivate them, but also you don't want it to put them off. If they can do, hardly any calf raises, giving them a target of 20, if it seems unrealistic, is not a good thing to do either. But certainly it's going to be quite population and study specific, I think. So it's going to vary a fair bit. Yeah. So just go with what you think is go with your intuition, I think, and what you think feels right for your patient. I mean, this guy that I'm talking about him a lot, actually, this obese guy that I saw yesterday, because he's genuinely a really interesting patient. I like ones like that because they're so challenging. But this guy, I mean, if he can get to the point of doing 2 or 3 calf raises, I'd be really, really happy with that. So someone like that. And that's the sort of, you've got to shift the goalpost, I think, for certain people.
Start with the end in mind.
Yeah. Yeah, definitely.
Very good. Well, I think that wraps up a lot of the questions that have been asked through the presentations this evening. So if anyone else, and if you do have any last minute questions, feel free to fire away in either the chat or the Q&A or the Q&A. But just to let everyone know, we did make a last minute decision to record this as well. So we will actually look to publish it on our YouTube channel. So if you head to YouTube and just search for Complete Sports Care, we'll hopefully have that up within the next couple of days. I'll probably edit just a little bit, but yeah, that will be available. So thank you all for coming. And yeah, you can have that additional bit of information on the YouTube channel if you do feel like you'd want to watch it again. But thanks all for joining, and we will hopefully be doing a few more of these, I think, in future. It was pretty successful tonight. We did get a fair few registrations. So yeah, thanks for all supporting us, and thank you to the 2 presenters who presented very solidly tonight.
Thanks, Dave.
Thank you, Dave.
Thanks, guys.